and will have an anechoic lumen. Pulsations will be of the abdominal aortic ultrasound examination. The normal aorta will have a diameter of less than 2.5 centimeters at its widest and will have an anechoic lumen. Pulsations will be clearly visualized during real-time scanning. It's important to remember that even a normal aorta may have some degree of ectasia. Atherosclerosis, which is a risk factor for development of aneurysmal formation, will produce thickening of the intimal layer. As the degree of atherosclerosis progresses, plaques will be noted. In this video, you will see multiple echogenic plaques within the lumen of the aorta on this sagittal video. Overall, however, the aorta measured less than 2.5 centimeters at its widest, so no aneurysm was present. Note in this transverse video the presence of multiple echogenic plaques within the lumen of the aorta. You can see these as you're following the aorta caudally to the bifurcation. This patient has atherosclerotic disease without aneurysmal formation. This patient on the left has an irregular appearance of the aorta with multiple echogenic plaques present. No aneurysm, however, is present. In this patient, the aorta measured at its widest 2.2 centimeters. In the patient on the right, note in this transverse image that there is marked thickening of the intimal layer of the aorta, affecting the diameter of the vessel lumen. However, no aneurysm is present at this level. You can also see on this transverse image the left renal artery coming off and the right renal artery coming off. Criteria for diagnosis of an abdominal aortic aneurysm include focal dilatation of the abdominal aorta of more than 3 centimeters. Here you can see in this aorta on the sagittal plane that it measured 4.69 centimeters. And at this transverse level, you can see that the aorta has an AP diameter of approximately 5 centimeters and a transverse width of approximately 5 centimeters. This meets the criteria for diagnosing a AAA. Other criteria used for making the diagnosis of a AAA include an increase in the aortic diameter to 1.5 times the normal expected diameter and a ratio of the infrarenal to suprarenal aortic diameter of 1.2 or greater. In this module, we will be using a diameter of greater than 3 centimeters as the criteria for making a diagnosis of a AAA. Please note that color flow Doppler is not required to make the diagnosis of a AAA. In patients with AAAs, mural thrombus is frequently present. Note in this patient on the left that there is a relatively large amount of thrombus present. Now, the degree of thrombus formation can vary from patient to patient. If you look at the patient on the right here, who also has a very large AAA, you can see that there is very little thrombus formation present. Some have suggested that mural thrombus may provide a cushioning effect and decrease risk of rupture, while others have suggested that the site of aortic rupture occurs in 80% of cases where thrombus is present. So the bottom line is there's no definitive answer for this. If you take a look at this patient on the right here, even though there's very little mural thrombus present, this patient was found to have a ruptured AAA. There was a crack in the parietal lumen present right here, and this was a very large amount of retroperitoneal hematoma. So the amount of mural thrombus present cannot be used to risk assess the patient. Let's take a look at the morphologic shape of the AAAs. Fusiform aneurysms are the most common type. They will appear sonographically as symmetric enlargement of the abdominal aorta secondary to a circumferential weakness of the aortic wall. And what you'll notice with the fusiform aneurysms is that the transition point from normal to aneurysmal formation is gradual, as you can see here on this sagittal plane. You go from no aneurysm to gradual formation of the aneurysm. Saccular aneurysms are localized dilatation with eccentric outpouching of the aortic wall. Some have suggested that the aortic wall strain is greater at the transition point in these aneurysms, making them more likely to rupture at smaller sizes. It has been suggested that wall stress and wall strength are more reliable parameters in predicting the risk for rupture rather than maximum diameter alone. This was a patient that had a saccular aneurysm. You can note the relatively abrupt transition point here, and here on this sagittal view is the aneurysm. Note that Doppler was used in this image but was not necessary to make the diagnosis of the AAA. Hourglass aneurysms are two non-contiguous areas of focal dilatation of the aorta separated by a normal caliber aorta. Here you can see a three-dimensional recon of a patient with an hourglass aorta. You can see the two non-contiguous areas of focal dilatation. On the ultrasound, you can also see here the two non-contiguous areas of focal dilatation, and then the separation by normal caliber aorta. Suprarenal aneurysms will be present above the renal takeoffs, while juxtarenal aneurysms involve the part of the aorta in which the renal arteries originate and often involve the renal arteries. Infrarenal aneurysms occur in over 90% of cases and originate below the renal takeoffs. Therefore, it's essential that the distal aorta is visualized when scanning the aorta. This patient here has a suprarenal aneurysm that extended or that began up in the thoracic cavity. Here you can see the liver as a window on this sagittal view, and you can see that there is aneurysmal formation present proximally. So it's really important to determine the location of the AAA. While the emergency physician's job may be completed after the diagnosis is made, the location of the AAA is essential for the vascular surgeon in determining operative management and planning. Over 90% of AAAs are infrarenal. The renal arteries are best visualized during the transverse scan. However, the renal arteries may be difficult to visualize in the acutely ill patient. Remember that the vast majority of people, the renal artery takeoffs will be within 2 centimeters of the SMA takeoff. This can be easily assessed during the sagittal scan, and while this information may seem of little significance to the ED physician, again, knowing whether the aneurysm is infrarenal or suprarenal can be very helpful to the vascular surgeon. This patient was found to have an infrarenal AAA. If you take a look, here's the celiac artery, here is the SMA. At about 2 centimeters from that takeoff, there was no aneurysmal formation present. The aneurysm was much farther caudal. This was an isolated infrarenal AAA. This patient had a ruptured infrarenal AAA confirmed in the operating room. Note that due to the tortuous shape of the aorta, that identifying the renal arteries in this acutely ill patient is difficult. The sagittal view provided a better estimation that the AAA was infrarenal based on the distance of the aneurysm from the SMA takeoff. But just take a look at this video as it recycles again and see how difficult it is to determine the location of the renal arteries. What about diagnosing aortic rupture with ultrasound? Rupture of the AAA is the most common complication and is associated with a high mortality rate of almost 90%. Direct findings of rupture are infrequently seen with ultrasound, and that's the problem. The most common ultrasound findings of AAA rupture include retroperitoneal hematoma, which you see here. This is a transverse view of a patient with a ruptured AAA. So you have anterior, posterior, patient's right, patient's left. Here's a very large AAA, and you can see at about the 9 o'clock position, there's a direct break in the parietal lumen, and you can see the blood leaking into the retroperitoneal space. If you didn't see this hypoechoic or anechoic area here, the remaining portion of the retroperitoneal hematoma would be difficult to definitively diagnose. You may also find hemoperitoneum in these patients when you look in the perihepatic window, but that's not a very common finding and usually implies intraperitoneal extension. So it's important to remember that while you can determine the presence of aortic rupture with ultrasound, absence of these findings does not exclude the presence of aortic rupture since the sensitivity is low. In this patient with a confirmed ruptured AAA, note that minimal mural thrombus is present, and you can see at 9 o'clock the crack in the parietal lumen. You can also see that there's a retroperitoneal hematoma present adjacent to this area. And again, note that with this predominantly echogenic hematoma, it would be difficult to distinguish from bowel. And you can see now on the video here, you can see how the wall on the side where the rupture has occurred has been bowed in. And here you can see a better look at this large retroperitoneal hematoma. So again, the sensitivity for determining rupture with ultrasound is not high, but it is possible. Note in this transverse video that again, there's a large AAA present. Also note that while direct evidence of a break in the parietal lumen is not visualized on this video, there is free echogenic fluid surrounding the aorta in the retroperitoneal space. Because of the similarity in the echogenic appearance to the surrounding bowel, this can be very difficult to diagnose. But this was a patient who was confirmed to have a ruptured AAA in the operating room with a large retroperitoneal hematoma. In this sagittal video of the same patient, again, note the presence of retroperitoneal hemorrhage anterior to the aorta. But again, note that this echogenic fluid could be very difficult to identify. So you get the idea that the poor sensitivity of ultrasound in detecting retroperitoneal hemorrhage has been well described. Since the retroperitoneal spaces can also be visualized from both the perihepatic and perisplenic windows of the FAST exam, I would advocate looking here for the presence of retroperitoneal fluid. I have frequently found free fluid around the kidneys and have been better able to visualize it in these locations. Since retroperitoneal hematomas are more frequently found on the left side, the sonologist should take a look in both the perihepatic and perisplenic windows. You can begin with the perihepatic window since it is relatively easy to perform. Here's a patient with a ruptured AAA. You can see here, this is a well-contained fluid collection. This was a renal cyst. But if you look adjacent in that area, there's a rim of free fluid surrounding the kidney. That was retroperitoneal hemorrhage that had extended around the kidney from the ruptured AAA. Okay, so let's take a look at this perihepatic window. This was a patient who had a large AAA. Direct findings of rupture couldn't be seen when the aorta was scanned either sagittally or transverse. However, when we went to the Morrison's pouch window, you can see here's liver, here's kidney, here's the retroperitoneal fat. There's some fluid in Morrison's pouch, but there's also some free fluid present in the retroperitoneal space. So the presence of the retroperitoneal fluid in this patient with a very large AAA made it much more likely that this patient had rupture. He was emergently taken to the operating room where he was found to have a ruptured AAA. Here was another patient who had a ruptured AAA. If you take a look in the perisplenic window here, you can see again that there's a fairly large stripe of fluid in the retroperitoneal space surrounding the kidney. This was a patient who had a ruptured AAA, and the retroperitoneal fluid was best visualized in both the perihepatic and perisplenic windows, not anteriorly. So keep that in mind. Don't forget to look to the kidneys. Let's take a look at this patient who had a ruptured AAA and a very large retroperitoneal hematoma. Looking up by Morrison's pouch, you can see here's the right kidney. You can see that there's a cyst within the kidney here, but you can see this large complex hematoma surrounding the kidney here. You can see on this view that there's a small amount of anechoic free fluid visualized adjacent to the kidney. And you can also see that the kidney is tipped up and its normal position is distorted due to the presence of this large retroperitoneal hematoma. This patient subsequently died after being taken to the operating room. But again, look at the kidneys. You can see that the retroperitoneal fluid is, or the hematoma is, very well visualized here. So this patient here on the transverse view is noted to have a AAA. The widest diameter was 3.5 centimeters. But as we followed the aorta down farther, you could see that this patient has bilateral iliac artery aneurysms. And this was where the pathology or the acute pathology was for the patient. This patient had rupture of his right iliac artery aneurysm. So remember, a minority of patients may have isolated iliac artery aneurysm, so you want to try and evaluate as much of the iliacs as possible. As a refresher, the normal common iliac artery in a male should be no larger than 1.5 centimeters in diameter, and in a female should be no larger than 1.2 centimeters in diameter. A pseudoaneurysm is a focal outpouching from the aorta resulting from the disruption of one or more layers of the aortic wall. They account for only about 1% of all abdominal aneurysms, and the most common cause is trauma. And the patients who have a post-traumatic pseudoaneurysm may not be symptomatic for years. These may also develop from large penetrating atherosclerotic ulcers, and rarely mycotic aneurysms may be the cause. This was a patient who you can see on this transverse view. Here you've got the aorta, and here you've got this outpouching posterior and to the left. And you can see on CT confirmation that this was a large pseudoaneurysm. And you can see that there was some contrast extravasation into the pseudoaneurysm. So these are not common at all. Like I said, they only account for about 1% of all aneurysms, so it's very unlikely that you're going to see these, but I thought I'd throw this in early on so that you can be aware of what the sonographic findings of a pseudoaneurysm is. Let's take a look at aortic dissections. Again, this is not the primary goal of the focused aortic evaluation. However, not uncommonly, these patients may present in a similar fashion. So you may be doing this study to rule out a AAA, and you may end up finding a dissection. So a dissection is a tear in the intimal layer. A type A dissection is going to involve the ascending aorta, while a type B will involve the descending aorta. So both of these will originate up in the chest, but if they extend down into the abdominal aorta, you will see them easily with ultrasound. And here you can see on this sagittal view of the aorta, there's an echogenic intimal flap present, which is diagnostic of an aortic dissection. Here's another patient who also had a dissection, and you can see on the sagittal view that there's a large intimal flap present in the abdominal aorta. This was a patient with a type B dissection that extended all the way down to the iliacs. Now, it's important to remember that these patients do not have to have an aneurysm present also. They're two totally separate disease entities. And here you can see on the transverse view again, there's the intimal flap present within the lumen of the aorta. So again, not the primary goal of this study, but something you should be aware of, since you may go in looking for a AAA but end up finding a dissection. Here we have a sagittal view of the aorta, and remember, the normal lumen of the aorta should be anechoic. However, if you look here, just below the takeoff of the SMA, you see this echogenic line within the lumen. So the question is, does this represent a dissection? And the answer is no. Remember, dissections originate up in the chest, so it'd be very rare for one to start distal to the takeoff of the SMA. This is just a reverberation artifact due to this line representing the anterior wall and the soft tissue of the and of the surrounding soft tissue by the anterior wall of the aorta. And you can see that this is present here just as a focal echogenic area, and you can see it on both sagittal and transverse planes. But remember, this is not where you would expect either a type A or type B dissection to originate, so this is just a reverberation artifact that you need to be aware of. Now, this concludes the abdominal aortic ultrasound interpretive video.